I tried to do this one day before, but it said I had too many meetings on the go.
Okay. Done. Okay, and now I can share my screen with the, when I go into,
I did this one day before, but it said I had too many.
oh, it's good. So there's a little lag.
Yeah.
But I will need to, how will I get that sound? I can just, can I mute it on
Yes,
YouTube?
absolutely.
Okay, and now okay, so I'm muted on YouTube, but will that mean other people won't be able to hear it?
No. Other people can hear it. This is basically just on your end in terms of.
Okay,
Yeah.
so my YouTube is muted, but other
Yeah.
people won't be
Yeah, if
muted.
you want to mute yourself, of course, you mute yourself.
Okay, so here with this one, what do I do? Can I just minimize it?
Yep, you can get that open. Live stream.
Got it. Okay.
People have entered the waiting room.
I didn't do a waiting room for this. I asked specifically for there not to be a waiting room. Can I change the meeting settings for that? I'm going to stop my video now. Hi, Anders. Okay. Hello, Anders. This is Rochelle.
Hi, Rochelle. Hi.
I'm just going to lower my blinds because I'm very backlit.
Sure. Yeah.
Bear with me one
But I do see you.
Okay.
I'm just gonna clean up the desk here.
That's a little better, I hope.
Yeah, that's pretty good.
You can hear me okay, and others on the line can hear me?
Absolutely. Yes, sure.
I just realized, and we're working to troubleshoot it now, that I had set up this meeting with a waiting room. I hadn't intended for there to be a waiting room. So my coworker is going to log in, and I'm going to let him manage folks who may be waiting, because we don't
Sure.
want
Good
folks-
thing. No, absolutely not. No,
I
I
don't
understand.
like waiting rooms.
Neither
one
do I. Mm,
So Anders, did you wish to attempt to share those landing slides that Nathaniel had sent?
yeah, I'm just trying to find them.
Okay, and I've got to just change my sharing option.
Thing I have. Yeah. Let's see. Sure, I got them here.
Okay.
Yeah, well, let's see. So Nathaniel said something that I have a meeting, so, but the second slide includes an announcement for the. Okay, so what we do is that you do a brief introduction. Is that so? And then you'll hand over the word to me.
So how it's going to work is I will welcome everyone to the meeting. We have a huge attendance list. So I think we've got about 58 or 59 people joining on the Zoom call. So the first thing I'm going to do is set up my coworker Tyrone White to let people in from the waiting room. So I won't be constantly distracted by letting people in. And then when we hit the start time, which is in another 14 minutes or so, I will start by introducing it, welcoming everyone, running through quickly the protocols, and then I will hand things over to you to introduce the speakers. And hopefully the speakers, Jose, I see you're here, welcome. Hopefully the speakers will be able to share their screens. I have it set up so everyone should be able to do the screen sharing, and they can give their presentations in the order I understand it to be today, which will be Anne, and then Wayne and Jose, and then John, and then Henrik.
Yes.
Okay.
Right. And I think that Henrik, he'll join later, and that was what he said from the beginning, because he's having a meeting in the COVID crisis stuff right now. So but he'll join later.
Okay, excellent. Tyrone, I'm going to make you a host now so that you can let people in. So I just go to your name. More. And I've, no, sorry, Tyrone.
Yeah, I'm now a co-host.
Wonderful. So are you able then to manage the admitting of people into the waiting room as they come online?
I should be able to. I haven't seen anybody come online yet, but as soon as I
Yeah,
see
I've just admitted everyone that was on my list, but if you see them, let me know and see if you can manage that.
Yeah, that won't be a problem.
Okay.
If I can.
Okay.
Hi, Wayne.
Good morning. I'm just loading up the deck.
So Wayne, because we're sharing the slides, and I think I'm starting, right? Do you want me to just advance the slide for both of us?
Okay, that sounds good.
Yeah, I think that
Yeah.
would be easier than
Awesome.
going back and
Okay.
forth. Okay.
Perfect. How are you today, Jose?
I'm very good, thank you. How are you?
Good, thanks. Yeah. It's a nice day here. It's last day of summer.
Yeah, it's beautiful. We're having a mild fall. My garden is still in full swing.
Yeah. I actually like this time of year.
Yeah.
I'm one of those people that actually likes winter.
I think after ranking in that, it's not really winter, right?
No.
I have to remind myself, -30 is not really that cold. So Rochelle was just giving us a few instructions. I think she's going to start and then introduce Anders, and then Anders is going to introduce the speakers.
Okay.
So I think she was explaining that just at the end of when you came in.
Okay. I'm just going to grab something.
Michael? Michael?
Hi, Wayne.
Hi, good morning, Rochelle. How are you today?
I'm very well, thank you. How are you?
Good, thanks.
You and Jose are going to co-present, as I understand.
That's right.
So did you want to test your slide sharing capacity, or are you confident that you can do that in Zoom, having done it throughout the pandemic?
Right. Jose is going to manage the slide sharing.
Okay, yeah, that worked.
There it is. Just
Okay,
perfect.
perfect.
Thank
So that
you.
worked?
That looks awesome.
That looks beautiful. What a gorgeous
Yeah,
image.
isn't that nice?
Yeah.
Jose, where's the picture? Is that Rankin or further north?
You're still sharing, Jose, so you may wish to stop sharing at this point just to,
Oh, yeah, and you're
as we're getting
muted
started.
as well.
Thanks.
There you are.
And I'm not sure whether we have any other planned speakers on the call at this stage. Yes, we have John.
I'm here.
How are you?
Oh, I'm perfectly fine.
It's good to hear.
After-
Welcome.
Thank you.
Did you wish to test sharing your slides before we get started, just to make sure that the technology is working okay?
Oh, yes, I would. Should I just push this share screen?
Yes.
Okay. I think I am fine.
That worked. Perfect. Thank you so much. So you can stop sharing now. We know that that works.
Rochelle, I sent you a message.
Yes, I got it. I'm just
Yeah.
answering it with the words, of course. Okay. We've got about 7 minutes before our official start time. So I'm just going to turn off my camera for a second and do a little housekeeping around my office. Make sure I have all my notes together, and I'll be right back. Good day, Dr. Hansen. How are you?
Fine, thank you.
Would you like to try to test the IT and try sharing your screen and make sure that that's working okay for you?
Yes, I will try that. Can you see the screen now?
We can see the list of all your slides. So what we can see is your file system on your computer, but you'll need to open the actual PowerPoint and make sure it's on the same screen that you're sharing.
Yeah, the problem is probably that I have 3 screens. So how do I find the right one?
So you can select in Zoom which screen you prefer to share. I think it'll show you a little picture of each screen, and you can click on the appropriate one when you go into share screen. So you might want to stop screen sharing for a moment and then try again, selecting the screen where the PowerPoint is open.
So what are you looking at right now?
I'm seeing the screen that has your list of files with COVID-19 at the top of the list, but it's a long list of all of your files on your computer.
Is this one better?
No.
No. You're still seeing this list?
I'm still seeing the list page, yeah. So perhaps if you minimize that or exit it out of that, yeah. Now we're not seeing anything. So when you see share screen at the bottom, it should give you a choice of monitors when you click there. So you'll want to select the monitor to share as being the one where the PowerPoint is open and in display mode, if you've got that. Yep, that's it.
Is that
Perfect.
better?
Perfection. Yes, thank you.
And then you make, I suppose I put on this slideshow, then it goes on the other screen.
Exactly.
Can you still see the PowerPoint now in full?
No, we're seeing the slide view where we're seeing all the slides down the left-hand column.
Okay, then I'll see if I can change that.
Okay. Even if you can switch, I'm not sure how well that will flip in PowerPoint, but we'll try that again. We've got a few minutes, no worries. That's it.
Is that better?
Perfection. Yes.
Okay.
That gives us
okay.
the right view. So thank you so much.
Okay. Then I will stop it again.
Right.
Yes.
Okay, wonderful. So by my time, we have 3 more minutes before we get officially started. And I notice lots of people are still joining. So again, I'll turn off my camera for a few minutes as people settle into the meeting. Okay, I think it's time for us to get started with today's webinar. Welcome everyone to today's webinar, Circumpolar Perspectives on the COVID-19 Pandemic, Moving Beyond the Numbers. I think at this stage in the pandemic, we're all familiar with Zoom, but I've left you an email for technical support. If you have any difficulties with today's meeting, please feel free to contact our IT support person, Tyrone White, who is at the meeting today, but also available to help you through any technical issues you may be experiencing in connecting with us today. For the purposes of bandwidth, our recommendation is that people turn off their cameras while the speakers are presenting. This tends to free up room for people who have bandwidth issues with their connections. To turn off your camera, most of you know this, but just in case, there's a little icon that looks like a film camera and it has the word stop video under it. If you click on that, that will turn off your web camera during the presentation. So today's webinar is hosted by the Research Exchange Group on Rural Health at the Newfoundland and Labrador Centre for Applied Health Research at Memorial University in St. John's, which is convened by Dr. Nathaniel Pollock, a research associate with the School of Arctic and Subarctic Studies at the Labrador Institute of Memorial University. But this event really is an excellent example of collaboration among organizations. And we would really like to start off at the outset by thanking the International Union for Circumpolar Health for inviting our Research Exchange Group on Rural Health to be a part of this webinar. We appreciate the opportunity to meet and connect with all of you. For our part, the Research Exchange Group on Rural Health at the Newfoundland and Labrador Centre for Applied Health Research is at Memorial University in St. John's, Newfoundland, and we're playing Zoom host for today. We'd like to thank Dr. Pollock, who is the convener of our Research Exchange Group, for gathering such a fine group of speakers from all across the globe to talk to us today. So today's session is sponsored by the International Union for Circumpolar Health and has also been supported by the School of Arctic and Subarctic Studies at the Labrador Institute of Memorial University. The facilitator for today's webinar will be Dr. Anders Koch, adjunct professor at Illis Imattusarfik University of Greenland and chief physician, infectious disease, epidemiology and prevention at Statens Serum Institute, SSI, in Copenhagen. At the Department of Infectious Diseases at Rigshospitalet University Hospital in Copenhagen, and at the Department of Internal Medicine at Queen Ingrid's Hospital in Nuuk, Greenland. Dr. Koch is also past president of the International Union for Circumpolar Health and the president of the Danish Greenlandic Society for Circumpolar Health. Dr. Koch conducts epidemiological research in Greenland and in Denmark. His research activities in Greenland primarily include infectious disease, epidemiological issues within a number of particularly prominent infectious diseases, including tuberculosis, respiratory infections and otitis media, HIV, and other sexually transmitted infections, invasive infections, viral hepatitis, and zoonotic and parasitic diseases. I can't believe I got through all the long words, but I did. And I apologize for my mangling of Danish parlance. I was saying to Anders before today's talk, my Danish really could use some help. So I'll pass things over now to you, Dr. Koch, to get today's webinar underway with our thanks for all of you for joining us here today.
Thank you so much, Rochelle. I think you did a great job in pronouncing all of the long words, also in Danish, or what comes close to it from what you were given. But it's a great pleasure as past president of the International Union for Circumpolar Health and member of the board of the union to introduce this webinar today on a very relevant topic, not only in the Arctic, but in the whole world. 2020, the World Health Organization declared the SARS-CoV-2 coronavirus to be a global pandemic. Since that declaration, the pandemic has reached millions of people across the planet and continues to impact global health. In the circumpolar north, the pandemic has also highlighted many of the long-standing challenges to health systems and the complexities inherent in managing infectious diseases in small and remote communities with limited resources. This webinar brings together public health leaders from Alaska, Canada, Greenland, and Northern Scandinavia to share their, to share their perspectives on regional experiences with the pandemic. The goal of this session is to look beyond the numbers and better understand the social and health system challenges and successes in diverse circumpolar contexts. In the past 1.5 years, the circumpolar collaboration has been put at a lower level than it used to, mostly because of travel restrictions, but also because of the occupancy or the much work that's been going on with COVID that has somewhat hampered collaboration in other fields. But it is therefore a true pleasure to introduce this IUCH webinar, and also to thank the Newfoundland Center for Arctic Health Research for arranging the practical issues. Regarding the IUCH website, I must offer you a disclaimer that the website has not been updated for a long time, but it will very soon. So please visit that when you can. Before we start, I would like to give the word to Professor Mikhail Voivoda from Russia, the president of the United or for the International Union for Circumpolar Health for some words. Professor Voivoda, please.
Thank you for introduction, Dr. Koch. Dear colleague, I am greeting you from Russia, more perfectly from Novosibirsk, Siberia. I am very happy to see you at this meeting. And on behalf of the IUCH Council, I want to thank the organizers of today's webinar, our chairman, Dr. Koch, and speakers kindly agreed to submit us the latest and most relevant data on the problem that now alarm all of us, the consequences of the coronavirus infection pandemic in circumpolar regions of our planet. We know that social life system in the northern regions is especially vulnerable and requires special attention to its functioning and emerging specific problems. I'm sure that today's webinar will be very useful, and I wish you all fruitful work, and I give the word for the chairman of session to past president of IUCH, Dr. Koch. Thank you again.
Thank you so much, Professor Voivoda. I would now like to introduce our first speaker today, and that is Dr. Anne Zink, who is the Chief Medical Officer for the state of Alaska. Dr. Zink grew up in Colorado and moved through her training from college in Philadelphia to medical school at Stanford and then residency at the University at Utah. As a mountaineering guide, she had fallen in love with Alaska, and after residency in emergency medicine became lucky enough to call Alaska home. Not only does she love people and the place, but also the medicine. Dr. Zink became the state of Alaska Chief Medical Officer in July 2019. In all the work she does, she strives to create work environments, policies, and practices that are data-driven, foster collaboration, and build system efficiencies that put patients first. Dr. Zink, please.
Thank you so much for having me here today, and it's great to see some familiar faces and meet some new people. So as mentioned, I'm the Chief Medical Officer for the state of Alaska, and did have the opportunity to take this job about 6 months before the pandemic hit. I had debated about doing some slides. We have some fantastic pictures, and I appreciate this group's focus on more than just the numbers and focusing on the stories and what this looks like in many of our remote and Arctic villages and communities. And I guess I'll start with a story because this story impacted me significantly at the beginning of the pandemic. So when we were all watching the world unfold last, February, March last year, we saw many of our communities really respond very viscerally to this pandemic. We have 229 federally recognized tribes in the state of Alaska, which is 40% of all of the tribes in the United States. And as many know, the 1918 pandemic took an amazingly traumatic and historic and devastating impact on Alaska people, particularly Alaska Native people. We had communities that completely protected themselves at gunpoint and were able to preserve their culture and their history. And we had other ones where between either mail or fishing, the 1918 pandemic entered and devastated communities. And so when the pandemic hit here in the state of Alaska, we saw communities learning from that history and that past and taking very similar measures, everything from putting trucks on their runways to prevent anyone from landing in that region to completely shutting down all transportation in and out. Much of our communities are really reliant on commercial fishing and or subsistence hunting or fishing to be able to maintain their economic standpoint. And the Bristol Bay region, which many are familiar with, is a huge economic driver, not only for the region, but also the state as a whole for fishing. We were all concerned about food shortages and supplies and saw a federal movement here in the United States to keep open things like meat packing plants to make sure that there was food supply in the setting of this worldwide pandemic. And the fishing industry also saw similar challenges and the need to keep the fishing open, yet the concern with people moving into those communities. So a group of us flew to Bristol Bay early on in the pandemic to hear the stories and the concerns. When we landed, it was two protesters on the runway as well as along the streets, really advocating for a complete shutdown of all movement to and from any sort of region within Alaska, given the challenges of this pandemic. And we had a community meeting with tribal elders. One tribal elder, Chief Tilton, told a story about his family from the 1918 pandemic, where his grandmother took his mother and siblings out to the woods and had told them that no pandemic lasts forever. She didn't use the word pandemic, but no infection lasts forever. The 1918 pandemic is oftentimes referred to as the big illness or the big death here in Alaska, and that no death would last forever, that they needed to go to the woods and that they would come back for a year and they would see where things were. So took the entire family out, lived on their own with no other connection to others for a year. And when they came back to Dillingham, they found their community devastated. They found children and dogs alive. They saw most of the adults had passed away and died during the 1918 pandemic. There were orphans running around the streets, and the devastation was remarkable. He told the story with tears in his eyes and explaining that history that was told to him every single year. And in fact, the Dillingham Hospital is built in the orphanage that was created out of the 1918 pandemic. He then went on to talk about 100 years of trauma and lost history, lost culture, and how many had let go of their religion and their cultural identity in belief of the white religions and identity, because those were the people who had not died in the same way as the Alaska Native people, and how that affected generations of Alaska Native people. And he felt like he had been told this story again and again to ensure that this never happened to him or his community or in his tribe. And so he was going to do everything in his power to be able to support his community and protect them from this worldwide pandemic. I think that oral history of our amazing Alaska Native tribes really influenced our entire response from the beginning of this pandemic. And it became clear that processing some of the trauma of the 1918 pandemic was going to be as important as anything like testing or vaccination or other resources, that history shaped and influenced the way that we would have to respond, but was also a trauma that needed to be healed in the same process. And so with that, there was a lot of engagement with our tribes from the very beginning on the ways that they could be able to keep their communities safe and healthy. So there was no statewide mandates for much of anything, but really allowed communities to be able to respond in the ways that they saw best fit for their communities. Alaska is bigger than California, Texas, and Montana combined. We have more coastline here than the East Coast and the West Coast of the United States combined. And we've had communities that have never seen a COVID case, and we've had communities that have just been devastated by COVID, and were unable to transport people in and out, secondary to weather, and horrific stories of people dying secondary to lack of oxygen. But allowing communities to be able to set up their own boundaries and their own restrictions has allowed communities to have much more buy-in and input into the process. And I also think process through many of the challenges of the 1918 pandemic overall. When we set up our vaccine rollout, we did it in combination with our tribes. We felt like we had to have them at the table at every single step of the way. We were stepping on each other's toes a lot at the beginning, and we really saw that with testing, they may be able to get certain resources, and we got certain resources, and they were sent to one region versus another. We also saw that we needed to have different tools here in Alaska, given the remote geographic nature of it, than many other regions. We put a really large emphasis on rapid testing from the very beginning, because we knew that it may take a week to get a plane with some swabs to be able to run a PCR. And so having local access to testing was going to be fundamental. We put a big emphasis for us on rapid testing, such as the Abbott Now, and most of our villages have access to rapid testing, such as the Abbott Now testing at home. When we started to get a lot of cases in our YK Delta, they were just really struggling with getting on top of it. Our YK Delta region it's huge, it's about the size of Oregon, and it is an area that has about 60 different villages, ranging anywhere from about 50 people to about 3,000 people. In that region, 60% of the communities don't have access to regular water and sewer, and we saw numerous multi-generational houses really being impacted by COVID-19. It's our region with the highest tuberculosis rates, as well as highest RSV rates, secondary to many of the living conditions in that region. And so they made a decision last fall when they were seeing a ton of cases to switch their testing from PCR testing to twice a week antigen testing for essentially their entire population. So we moved to the Buy Next Now cards because they were much cheaper, they were accessible. The one problem is they can freeze. So for those of you in circumpolar areas, which it's all of us, and that became a bit of a challenge. And so they had to be very carefully stored and carried so that they would never freeze. The good thing is they change color if they do freeze. And they were able to use those Buy Next Now cards throughout the region. And what they saw was a plummeting of their cases. As Dr. Ellen Hodges, who is the chief medical officer in that region, says, information is power. And the biggest thing that would drive change in people's behavior about COVID-19 was to know that they were positive or someone in their community was positive. She could do as much education in as many languages as needed, but that wasn't going to drive change in the same sort of way as being able to inform people of their positive status. And so being able to have rapid access to antigen testing was a game changer. And they actually were able to publish their research and their experience in an MMWR in combination with the CDC. And happy to link that in the chat box because that really was a big difference for us. When vaccines started to become available, as I started to mention, we built in that tribal leadership at every aspect from planning. We do have a distribution process in Alaska that's a little bit different than many other states. We have been used to, like many of you are, about weather challenges and distance challenges and the fact that you may not have, a full 1,116 people in one region who would get a Pfizer tray. So we had to think about the ways that we were going to do vaccine differently. We also didn't want to wait for a 1 dose or an easier to ship vaccine. So we went ahead and moved forward with what was most readily available to us here in Alaska, which was both the Pfizer and Moderna, the mRNA vaccines, including setting up negative 80-degree storage in some of our most remote locations, including on Alaska and Bethel, so that they could work as hubs for their remaining regions. And then each region went to work on their own on creating a system to distribute vaccine. Honestly, in many ways, that was the highlight and high point of this pandemic, was watching our communities own vaccine distribution and respond in culturally appropriate ways that were a priority to them. So we had many tribal regions prioritize language speakers or cultural leaders as people who were going to be top priority for getting the vaccine. And seeing those cultural leaders and heroes in their community choose to get vaccinated then helped to inspire vaccine confidence throughout the community as a whole. And as mentioned, we have some regions where we have 100% of those eligible who have now chosen to get vaccinated. Most of our work in rural and remote communities involve community health aides, who are local leaders who have been trained in health. They are there to help to promote the health and well-being of their community. And when they were advocates of vaccine, we saw a higher uptake in vaccine in general. Different communities did this in different ways. Again, the Waikiki Delta region, which is huge, they set up what they call Project Togo in a nod to the Iditarod in diphtheria. And they basically went runway to runway between villages, and people would snow machine up to be able to get vaccinated depending on their risk level. So first, their community health workers and their elders were brought forward. They also went everything from dog sled to ships to go from house to house to be able to offer vaccine. And in many of our industry, we were also able to offer vaccine on ships, including using things like man baskets to swing from one to another, and had to pivot a lot secondary to weather. This was all last December and January with a lot of bad storms at the same time. So lots of pivoting on transportation needs to be able to offer vaccine. Unfortunately, now Alaska is suffering a really big surge given the Delta variant. So we, as of this morning, just ranked first in the nation for number of cases per 100,000. We unfortunately have a lot of COVID circulating in Alaska right now. We started off with really high vaccine rates. We were the most vaccinated state in the country for over a month, but slowly, as misinformation has really taken hold and as a very libertarian and independent population continues to want to make decisions very much on their own, we've started to decline, and now we're 35th in the nation for vaccine uptake. And now it feels like every step is a huge and a heavy lift to get even one more person vaccinated. And we're seeing that really impact our hospitals as the Delta variant is spreading quickly. What we're really challenged with now in the state of Alaska with this big surge is the fact that our healthcare capacity is so limited. Weather is still turning bad. I just drove to work today in a snowstorm, and it is becoming harder to transport people in and out of communities. We also have just limited healthcare, and so we're starting to see remote and rural regions needing to hold patients for extended periods of time, and some of our major hospitals moving to crisis standards of care secondary to inability to care for patients. Dialysis continues to be one of our biggest limitations, both for COVID and non-COVID patients, as well as staffing, and continue to work with federal resources to be able to move forward. And so as we're struggling with this big challenge at this moment, we continue to look back on our history from the 1918 pandemic and before, and encourage Alaskans to dig deep into the strength and resilience that many people in the Arctic know and experience. We know how to get through winters, we know how to get through tough times, and we're really asking Alaskans to do that. We don't always have our snow tires on. We won't always have COVID. No pandemic lasts forever. But right now, we really need Alaskans to find that strength and support for each other that we were able to provide in different pandemics, as well as in challenging weather conditions as we struggle with what is turning out to be our biggest challenge yet during this pandemic. So thank you for allowing me to share a little bit of Alaska's story. Happy to take any questions, and I will hand it back over.
Thank you so much, Dr. Singh, for that really, really interesting presentation. We have room for a few questions, if anyone would like to ask some.
Hi, this is Tom Cabessi in Ottawa, Canada. Thank you for really emotional and fantastic summary of what's happening in Alaska. What are the vaccination rates currently among Alaska Natives and non-Alaska Natives?
Yeah, so fantastic question. So for the state overall, we're at 62.4% of those 12 and above in the state have received at least one dose, and we're 59% have received 2 doses. We do think our 2-dose is probably artificially low because we can only see what's been vaccinated here in the state of Alaska. We can't see where people have gotten vaccinated in other places in the country, unlike some systems like yours, where you may have a little bit more visibility between what happens between different regions. So that's a bit of a challenge. Amongst Alaska Native people, it is higher. So it's a little bit hard to calculate based on the exact data because we think that there's probably some over-reporting amongst Alaska Native people compared to others. But we are seeing rates more in the 70s in general. Most of our remote and rural regions, we're getting to 70 to 80% of the communities vaccinated. Interestingly, our North Slope region is one of our lowest regions, and that is a predominantly Alaska Native community. That one has been really influenced a lot by oil over time. And so some of the relationships and policies and politics are just really different in that region. So that's our lowest region of Alaska Native people who are vaccinated versus like the YK Delta, Aleutian Chains, and much of our Southeast are our most vaccinated. And again, it seems to be very much reliant on traditional leaders and their advocacy for vaccine. And the more that we see them being the voices and the messengers for vaccine, the higher rates we see. And last time we checked, we had about 5 communities with 100% of those 12 and above being vaccinated. So some communities with just incredible uptake. Thanks for the question.
Yen Joneskin has a hand raised.
Hi, Jen Jones from Yukon. Thank you very much. And I know it might be outside of your scope, but I'm wondering if in the work that you're doing or in how you are, or if you are kind of tracking some of the mental health issues. We've seen, we're hearing, we're not tracking it necessarily, increase in suicide, increase in self-harm, and these kind of outcomes of COVID in communities. And just trying to understand if Alaska is monitoring that, providing support through the COVID action. Do you have any comments on that? Thank you.
Yes, I very much appreciate that question. Sometimes I joke that I'm not the chief medical officer of COVID, but I'm the chief medical officer of the state of Alaska. And my job is to promote the health and well-being, and that includes the mental health. And I think it's really important that we're always including both physical and mental health in everything that we do and we speak about. Early on in the pandemic, we actually saw a decrease in both suicides and homicides in the state of Alaska. There was a lot of discussion about why that may be, but we saw it consistently across the state. Unfortunately, we're starting to see an uptake. And if we look at the past year, we've seen an uptake in both suicides as well as homicides, and then overdoses have also increased as well. We think that overdoses really decreased when there was just less movement. And so there was less fentanyl, less opioids entering our state, and people were not moving opioids across the state in the same way. But now that that's opened back up, we're starting to see an uptake in that. We've had a focus on mental health since the beginning. So for last year, just when we were spiking before vaccines came out, we had a big winter resiliency program, really talking about the importance of mental health and resiliency. I would say anecdotally, we are seeing more mental health challenges on our road systems where we have lower vaccine rates. We have more, honestly, social isolation in some ways versus many of our remote and rural regions. I do think that there has been an aspect of resiliency that has come about by being able to own vaccine as well as their testing, and to see communities really thrive in the sense that they've been able to control this pandemic. They've been able to protect their people, and they've been able to write a different narrative than what happened in their community in the 1918. I think is helping to create some healing, honestly, in some of these communities. I started off showing about Bristol Bay. They've done an amazing job of keeping COVID-19 at bay in their region. They were able to have a successful fishing season. They've been able to be productive economically, but they've been able to keep COVID at bay, and they have some of our highest vaccine rates in the state as a whole. So I honestly think that it's varied across the state depending on who it is, but I'm hoping that ownership of health will set a legacy for many of our communities that were devastated previously, of a new one of regeneration, of hope and healing, as they've been able to really own their health throughout some of this pandemic.
I think we have time for a final question by Laura Eichelberger.
Hi, Dr. Zhang. My name is Laura Eichelberger. I'm an epidemiologist at the Alaska Native Tribal Health Consortium. It's nice to meet you virtually. And I'm also living through this crisis here in Anchorage. I wonder, what will it take for the hospital to have them help serve the remote communities as well?
Yeah, I appreciate that question, Laura, and I see it in the chat box as well. The biggest thing that we're limiting right now in the state of Alaska is a lack of staffing. So we have applied for federal staffing. Unfortunately, between the combination of Hurricane Ida, the earthquake in Haiti, as well as many other states, we haven't been able to get supplies and resources like Samaritan's Purse and others that we had relied on as potential alternatives previously. So we are very much trying to get additional resources, primarily staffing, into the state of Alaska. We have set up daily calls with the state and with all of the hospitals to be able to load level and be able to support our remote and rural regions. We've also been able to work across the board with a kind of a crisis care committee to look at what are the limited resources and how can we support each other. I have to say, I've just been amazed and inspired by the resiliency of healthcare workers within the state and finding new and creative ways to continue to stretch and to support. And on our crisis care committee, as well as on these daily huddles, includes our remote and rural locations, so they can really share some of their expertise in keeping patients, as well as be able to express when things get backed up across the board. So we are doing a lot in that space, also purchasing lots of additional antigen testing to be able to identify cases early and working with the hospitals across the board. We actually have, I think, a press release coming out either later today or tomorrow with specific Alaska resources that we're doing to help support the hospitals. And then I did put in the chat box that MMWR from the YK Delta region on their use of the antigen testing. But I am hopeful that collectively Alaskans can be able to respond to this pandemic and start to really get more hospital capacity, increase our vaccine rates, and slow the spread in many ways. But thanks for asking that. And it's nice to virtually meet you, Laura.
So thank you so much for the questions. And again, Dr. Singh, for the talk and for the answers. Say Dr. Rhonda Johnson has put in a comment saying, so appreciative of our speakers and our Pan-Arctic gathering today. Participants may also be interested in some of the related articles recently published in the International Journal of Circumpolar Health, of which Dr. Johnson is the chief editor of. It's an open access journal, so it should be accessible to all, and there's a link provided. And second thing, before I give the words to the next speakers, is that I would just like to say that the next International Congress on Circumpolar Health that was postponed 1 year will be held next June 24th to 26th, 2022 in St. Petersburg, Russia, arranged by the Russian Society for Circumpolar Health. So there'll be more information about that. But back to the webinar, or back to the talks. Our second team of speakers will be Dr. Wayne Clark, who is the Executive Director of Indigenous Health at the University of Alberta in Edmonton, Canada. He is originally from Inuit Nuangat and is an enrolled Inuk beneficiary of the Nunavut Land Claim Agreement. Dr. Clark's research program focuses on the health, social, and cultural needs of Inuit in the development of educational interventions that foster community empowerment and decolonizing strategies. Dr. Clark will present with Dr. José G. Lavoie, who is a professor with the Department of Community Health Sciences, Faculty of Health Sciences, College of Medicine, University of Manitoba, and Director of Onkomiswin Research at the University of Manitoba in Winnipeg, Canada. Dr. Lavoie's program of research is located at the interface between policy and Indigenous health services, with a focus on contracting, accountability, and responsiveness. So please, Drs. Clark and Lavoie, the word is yours.
Good day, everybody. I'm Wayne Clark, and I'm presenting with Dr. Lavoie. I believe she's here. You're here somewhere.
I'm sorry, I was on mute, and I can't
there.
find a way to turn on my camera now that I'm sharing. But I hope that you're seeing the slides.
The slides are up, but they're still in the with the panel on the side. It's not full screen.
There we go.
Awesome.
Does that work?
Yes, it does.
Okay. Do you want to introduce yourself, Wayne?
Oh, certainly, yes. So, yes, I'm Dr. Wayne Clark. I am Inuk, originally from Churchill, Manitoba, with my family ties in Tikaraktouak, which is also known as Well Cove, in the Kivalik region of Nunavut. I'm Director of Indigenous Health Initiatives for the Faculty of Medicine, as mentioned. And I've worked with several Inuit organizations, and most recently with Manitoba Inuit Association, and working with Dr. Lavoie on several research projects. Thanks, Jose.
Thank you, Wayne. So good morning, everybody, or good afternoon, good evening, depending on where you are. Wayne and I will be talking about the result of a project, a research project that's been going on for the past 5 years in partnership with an Elders Council from Nunavut and also from Inuit living in Manitoba. And we'll be talking about the relationship between the Kivalik, which is a region of Nunavut, which is just north of Manitoba, the relationship between that region's healthcare system and the Manitoba healthcare system, as those two jurisdictions have long-standing relationship in terms of access to care that are related to how flight patterns have existed. So for the western side of Nunavut, Inuit do go to Edmonton to access services on a regular basis. The middle part of Nunavut, which is the Kivalik, come to Winnipeg. And then the eastern side, the Baffin Island, do go to Ottawa. Those corridors of care have existed for over 50 years. And in our research project, we were interested in finding out what are the patterns of service utilization happening in Manitoba, because there were no 5 years ago Inuit-centric health services in Manitoba. So at this point, the system has existed for over 5 decades, and yet there are still some weaknesses in the system in terms of jurisdictional issues of who pays for dialysis when an Inuk from the Kivalik region requires dialysis. And there was the case of that hit the media, actually, of a man wanting to go back home, but there was no way there were debates between the two systems as who should be responsible and how could that be operationalized. There are also issues with the lack of an electronic medical record system that can be accessed from both Nunavut and the Kivalliq, Nunavut and Manitoba, meaning that when patients do come to Winnipeg, they are accessing services, and yet that information does not always go back to Nunavut in a timely manner. And so those weaknesses have been known for some time. They are being discussed and worked on piece by piece. As a result of COVID, of course, weaknesses in the system, some of them were overcome, but some of them were exacerbated. Our study focused on two groups. We wanted to find out more about Inuit from the Kivalliq who come to Manitoba to access services, but we also wanted to find out more about Inuit who live in Manitoba. And we know we have a number. We have about 1,400 Inuit who we know live in Manitoba. We know it's underestimated, but it is a better estimate than what we've had access to in the past. So Wayne, I'm going to turn this one to you.
Great. Thanks, Jose. And so the seminal study that Jose has been speaking about has really enabled Manitoba Inuit organization to become more involved in health research. Given the tradition that the university has had providing care to the North through the previous Northern Medical Unit at the University of Manitoba, now known as Ongamazen Health Services, as well as the research partnerships that it has with other Indigenous communities in the province and the provincial and territorial organizations. So the picture at the beginning of the slide deck is our Elders Council, and the elders play a significant role in driving the research agenda and supporting the work that needs to occur to improve health. It's been known that there is no identifier in healthcare systems, but at the time of COVID, this also became an issue when tracking cases. So given that the Inuit from Kivalliq are coming to Winnipeg for healthcare services, they're also being potentially exposed to COVID and bringing it back to the territory. Essentially, there were, other than people that were working in travel, there wasn't any back and forth that there is normally, and so the tests that were occurring. Many of these were occurring in Winnipeg. So we were brought to the table with the Manitoba First Nations Health and Social Secretariat, who had already a template for how to add the, I guess, an identifier within the test and to then keep track of these tests on a wholesale level and then provide reporting. So this was significant because even though there wasn't anything within the health record overall electronically, there was still a way to look at doing this. And so this project of tracking COVID tests actually brought to light the issue of the jurisdictional issues and the challenges that exist at the point of care and with administrative data. With our project, the larger project that Jose was just speaking of, we were using data that was very aggregate in nature and provides us with some ability to look at data over a longitudinal span, and but this was something that was needed on the fly and something that could be used in real time. Next. So the data sovereignty that I was speaking of came from Indigenous organizations wanting to govern data and look at that in other ways that are being prioritized in their own goals related to health surveys, other kinds of surveillance around immunizations and other kinds of records that are important, that are shared between the federal and provincial government, on reserve, off reserve, and we were able to leverage some data governance structures that existed between the province of Manitoba and Manitoba First Nations Health and Social Secretariat. So that being invited to the table helped us with our desire to increase capacity in this area. And it was a real benefit to us to be able to piggyback on some of those relationships because of the complex dynamics that exist between the different structures that govern data or in the privacy and the other laws related to the data itself, but also the policies. So it was breaking down all of that that area that First Nations had done. We were invited to share in some of that knowledge, and that was how we were able to get the agreement with the province to look at Manitoba or an identifier that was Inuit specific in Manitoba. Next. So we came up with an Inuit specific approach. It had to be approved by the elders. And once we got their go ahead, we then looked at, okay, how is this unique to us and what can be important to inequities around monitoring and future research, recognizing that this particular project would live on past COVID and be something that would support other data requirements for other research that we wanted to do. Recognizing that Manitoba Inuit typically are Inuit from the Kavalik region, the relationship with Kavalik was super important because not only did it mean that it supported Manitoba living in Inuit living in Manitoba, but also there was our relationships with the North, and it could also be supporting that region as well. And I should just add the map that Jose showed earlier with the travel, all of the relationships and the travel lines between the North and the South. This issue that I'm speaking about in Manitoba and Kavalik is the same issue no matter where you go. I'm in Edmonton now, so that looks at Western Inuit in Inuvialuit, and also like Ottawa, Montreal, and St. John's. And so this particular project helps us to look at, how can we do effective tracking of Inuit within health information systems, but also how we need to integrate with and have better relationships. A lot of the relationships that were struck are quite old agreements, quite frankly, and they don't think about coordination and care in an outbreak surveillance scenario, and they weren't. These agreements weren't drafted with electronic health in mind. So there's addendums to the existing agreements that look at probably the basics in that regard. But when things occur in real time, it's not, people aren't sure on how to act. So when they pull together, disaster management planning and other kinds of incident command structures within health authorities and provinces, we need to consider how do we coordinate that information with our partnerships with Inuit. Next. So when I spoke about all of the people that we needed to bring together, first Manitoba Inuit Association was speaking with the First Nations Health and Social Secretariat. We needed research support from the university, which we wouldn't have had the resources to look at the issues in the manner that would be the expertise that would have knowledge about the health information systems, creating a data set that was Inuit specific, and so forth. And so we had a delegate from Montgomery Research, Jose, who sat on a provincial committee by Shared Health. And that's where the discussions around COVID was happening and continues to happen. So reporting that exists right now can be shared at that table, and also be spoken to in terms of the kinds of issues that are required in hotels and when Inuit are self-isolating, both within Manitoba and the Kavalik Inuit that are isolating before they return. I was also involved in that in my role at the Winnipeg Regional Health Authority, but also supporting Manitoba Inuit Association as a board member. And next slide.
Okay, so in terms of the pandemic itself, the first case of COVID-19 in Iqaluit occurred in November 2020. The first case in Manitoba was in March 2020. So even though Inuit from the Iqaluit continue to access essential services in Manitoba through the pandemic, Nunavut was very effective at trying to word out Inuit coming back with COVID from this region. The borders were closed to all non-essential services. And there was this policy that Wayne mentioned of 14 days self-isolation in Winnipeg in a hotel prior to return, which caused a lot of hardship. Especially we heard stories of young mom. If you imagine a very young mom, first baby, and instead of going back from being discharged to your family to have that surrounding looking after you and looking after baby with you, they were self-isolating in a hotel for 14 days. So that created hardship, but because of that interprovincial table, we were able to address that quite quickly. As of September 20th, of like yesterday, the number of cases in Nunavut by 100,000 and the number of deaths by 100,000 are the lowest in Canada. So Nunavut, by being able to manage its border, by imposing self-isolation, and also by being able to react quickly through community intervention, managed to manage the pandemic quite effectively. We also heard about community hunts to provide food hampers and mutual support in communities to those community members who had to self-isolate after an outbreak. There was some adaptation in terms of more care being provided virtually. We heard about chemotherapy being not offered in Winnipeg, but being relocated, some chemotherapy being relocated in Nunavut to prevent, again, the back and forth, which increased risk. And the same with birthing. The lack of the interoperational EMR did cause some concern. In some cases, patients were being tested in Manitoba for COVID-19, but that was not necessarily disclosed in a timely manner to their residents. So there was a risk of an outbreak in the residence here that where a patient go as a result of that. In Manitoba Inuit community, what we heard of is that challenge that existed before were exacerbated. A lot of food insecurity, a lot of emotional despair, a lot of the continuous problem associated with lack of responsive services, which validate why we need a Manitoba Inuit Association advocating for Inuit health. What we saw, though, is that the Manitoba Inuit Association was able to, after a lot of muscling, get its own vaccination site and have elders and knowledge keepers being prioritized. So answering to the priority of Inuit in terms of vaccination was something that was realized, and it elevated the Manitoba Inuit Association's role as an advocate for Inuit in Manitoba, which was a first. The organization was largely ignored by the Manitoba government until pretty much 2016-17. And through the pandemic, this was finally overcome. The poster that you see at the bottom of my slide is what resulted from, because of our project creating an identifier to identify Inuit in Manitoba Health Administrative Data Set. This report is being produced weekly and sent to the Manitoba Inuit Association and shared with Nunavut so that there's an understanding of where we are in the pandemic outbreak, where we are in terms of the vaccination. This is a first for Manitoba, but it's the only jurisdiction in Canada that is actually providing this kind of report to Inuit in terms of providing them with the tools to make decisions about what kind of supportive services should be provided. So Wayne, do you want to go through the conclusion?
Sure. So the conclusion here is that COVID data reporting has not only provided an excellent tool for sharing information between Manitoba and Nunavut, but also sharing information with patients and care providers. It's increased the communications between the Winnipeg Regional Health Authority and Kavalik nurses so that they are working together in a more streamlined way just because of all of the rules that exist now at a hospital or a health facility level. There's tools now in place to share information, but it also means that the Kavalik nurses are invited to the table to work with the Winnipeg region at the executive level, as well as it looks at future opportunities because, as Jose said, this is a first. We can look at building on this idea because now that we know we can do it, now we can look at even more improved ways to share information on any kind of chronic condition program, health program, or better care overall for ensuring like there's health services for Inuit, for whether that's advocacy or interpretation, that there's just more cultural safety, and then also I think probably most importantly, it underscored Inuit's right to self-determination over health and health systems. As health systems become more complex and really, manage the healthcare system overall and play such a significant role, Inuit have a right to give advice and share their goals and wishes for how they want information to be managed. So Manitoba Inuit Association, because it has a role in Manitoba where in the south where a lot of healthcare is managed, can support Inuit in the north to ensure that integration is possible. So we're really pleased to see that we were able to mobilize and work with the healthcare systems to make this a reality for COVID tests, diagnostic tests, but also looking at, how do we come together and integrate, and how do we work north-south in a coordinated way. Thank you. Yeah, that concludes our presentation.
Wonderful. Thank you so much for a really inspiring talk, and also it was great to see how an established project could be used when the area and the world is facing a pandemic like this. We have room for some questions.
Yeah, happy to answer any questions.
Well, I would like to ask one question then. Your project started some years ago, as far as I remember, it started 5 years ago. Did you turn your attention, or was COVID brought into the project from more or less the moment it emerged in the area?
Yeah, so I think I'll give a response, and then maybe Jose would like to share as well. But the project that started 5 years ago was essentially like the beginning of looking at, how do we want to look at health data or other issues that, govern health or that are important to Inuit. And we recognized that we couldn't do anything without the data. So we needed to find a way to get data to support our goals. And so that's when Jose stepped in with the U of M and the project, and then COVID became another project that spun out of that. It wasn't funded, but we were able to mobilize with the agencies across the province. And it just eventually further supported the need for, self-determination over health systems and data. Data comes out of health systems. So, and that was sort of the basis of the original project and continues to guide, I guess, other projects that we plan to conduct with the community in Manitoba and the community in Quebec. Jose, do you have any thoughts on that too?
No, you're absolutely correct. We created an algorithm to identify Inuit and administrative data set. And when COVID hit, we heard about First Nation being able to be identified and get the kind of report that I showed in my slide. And we were told that we can't do that for Inuit. And I said, wait a minute, we have the algorithm. You actually can. And Manitoba Inuit Association consented and in fact prioritized that and start pushing as well to have Inuit identified. But it was just accidental in the sense that the timing worked out. If we'd been applying for funding now, we would have missed that opportunity. It was just serendipitous in a way.
Great, thanks. Any other questions? Well, there's a comment from Rochelle saying that she can email links after today's meeting by email to all participants, including conference information. So thank you, Rochelle. But if there are no other questions, I would like to thank you both again for a very, very inspiring talk. And give the word to our third presenter, who is Dr. Jon Øyvind Odland, who is a professor in the Department of Public Health and Nursing at the Norwegian Institute of Science and Technology in Trondheim, Norway. So, Jon Øyvind, please.
Thank you very much. Just a quick introduction to myself. I'm an obstetrician, gynecologist. I live in the north of Norway, in Bodø. I've been working in Tromsø, and at the moment now I'm a professor of global health at the NTNU, the Technical University in Trondheim. My background is also that I've been working quite a few places in the world. I have a long connection to Russia since almost 30 years now. I've been living a few years in Africa, so I think I can see many dimensions of this pandemic we are into now. And most of all, it's quite interesting to see, first of all, in Northern Norway, we are quite well protected in this pandemic times. The interesting part was the big difference of the strategy between Norway and Sweden. Sweden had a much more open approach to the problem. We were so isolated that we even rejected any visitors from Oslo to north of Norway for a while in Sweden they have a much more freer approach. As you can see now, there is no big conclusion on this interesting study, as you can call it. Because at the end, we have almost the same number of diseases or deceased people. So there might be different options coming out of this. So, and also when we talk about the indigenous populations of Norway and Sweden, the Sami population is very much integrated into the population in general. So there were no specific strategies for the indigenous people in Norway. So that's also an important difference between us and what you have told us about from Canada and Alaska so far. So I will just now talk a little bit about my specialty. I'm an obstetrician. I work with pregnancy care, and I've done that in many parts of the world. What I've seen, first I will move from Africa back to Norway. In Malawi, where I have my other home, They have had a terrible situation, totally closed down. Still only 10% of the population is vaccinated. But at the same time, this quite young population, they have managed to cope with the pandemic in a maybe better way. Maybe, and there is a lot of things we don't understand so far about this. But the general thing about pregnancy is the fact that if you're pregnant in Russia, in Canada, in Norway, or in Africa, pregnancy is the same. The mothers, they care for their pregnancy, they care for the babies. There is no big difference in that. So let's start with that. This picture I show, this is actually from Greenland from many years ago when we worked in the AMOP, the Arctic Monitoring and Assessment Program, showing this Arctic dilemma, food security. And if you don't have food security, you lose your immune defense. And of course, that will make a population much more vulnerable. So this is the crucial part of life. I really need to show you a little bit of physiology. And also, when this the egg is penetrated by one sperm, there are maybe 50, 60 million dead or disappointed sperms behind him. And the next moment, he is losing his tail. So life is cruel in nature from the beginning. So this fantastic picture is taken by a Swedish photographer called Lennart Nilsson. What you need to know to understand how the virus and specifically COVID can have an effect on the baby, you need to know something we call exposure windows. Placenta develops from day 6 to 7 after conception. It's a facilitator and barrier. And you know, at different stages of the pregnancy, drugs, viruses, bacteria, parasites go through the placenta into the fetus, but different times. Toxic elements cross the placenta. Nutrition should in principle cross. So this is very important to understand how the virus will work out. If you come longer in pregnancy, I need to say, if you smoke 30 cigarettes per day, you don't even need to mention any infections or pollutants for that case. This is a totally destroyed placenta from my own practice, where a lady smoked 30 cigarettes per day and during pregnancy. And of course, that is a real big problem still in the Arctic. So many Arctic populations have problems with smoking, with drugs, with alcohol, and so on. So this is really an important thing. We should never forget it. And this baby born with this placenta, I call it a break of human rights. So this is so much more important than many other things we talk about. Just some very quick things about how we can measure the things going through the placenta barrier. There is often a threshold, there is a barrier, for instance, for the cadmium, for the toxic metals. As you can see, for cadmium, the baby is well protected, looking at the cord levels contra the maternal levels. For the lead and for organic pollutants, the totally opposite. And this has to do with the solubility. Solubility of the organic pollutants is lipid soluble. And that means a lot of it will go through the placenta. But this is just building up to what we want to know about the pregnancy and the coronavirus. Pregnant women might be at increased risk of a more serious course of certain viral infections, for example, in the case of influenza. And we do not yet know, we don't have real evidence what happened to the coronavirus compared to the influenza virus. But based on the available information so far on the global situation for corona, pregnant women seem to tolerate the coronavirus well. They are not especially vulnerable to a serious course of the disease caused by the virus. But once again, it has a lot to do with how vulnerable the individual is. Of course, we know from a long time, we know how rubella can have impact on the serious malformations in first trimester. Some other antibiotics can have the same effect if you if you give it to a mother who's only 8-9 weeks coming into the first trimester and so on. So we have a lot of evidence, but we are still collecting evidence on the pregnancy. So possible complications to be explored, and we are doing studies now, ongoing studies. So I really hope we can have much more epidemiologic information in a year or so now. Gestational age is a good endpoint to look for how the baby is behaving or how the well-being in pregnancy. Placenta damage, that's small for gestation, dysmaturity, prematurity, preeclamptic conditions for the mother. And of course, that will all build up to an increased frequency of cesarean sections. So then for the mother especially, should I take special precautions? To prevent infection, you should follow same advice as the general population. Now I talk based on what we have of concluded studies and ongoing studies. And they are not so many so far specifically for the Arctic. But that is not the big deal here, as I told you. To be pregnant is it's the same. You're just as pregnant in Africa or in the Arctic. So what should I do if I'm pregnant and at risk? If you have a chronic disease or pregnancy complications, of course you need to talk to your midwife or your doctor. And of course, if you are in a place with high incidence or spread of the virus, we have been so lucky in Norway so far because we still have hospital places and we still have quite good situation with the infectious pattern. But it's enough that there is coming some guy from outside to a densely populated group, and then of course the incidence is exploding immediately. We saw it with the Delta virus, but now that is really going down again. But we need to have a continuous alarm and to have precautions. So can the virus be transmitted from me to the baby? Now I talk about the mother, not me. And we do not know for sure whether it can be transmitted. But it's the same. You have to think principle for a virus. And that means that it's the first trimester that is a vulnerable time. And transmission via placenta has not been detected. So, of course, then the conclusion, you can give birth the normal way. The normal checkup routine should be followed. And of course, you need to know the situation around you. But if you are not infected, you're not in a contagious environment, just follow the normal routines. There is a lot of fear around this because all pregnant women, they are so caring or worried what happens to the baby. And we have to really come down to earth and give reliable information, not scaring people in a bad way. So that's a big responsibility for us. Coming back to some of the questions you've already heard about the mental health of the population in these serious times. And of course, we need to take care of all the sides of human health here. And the mental health of pregnant women is extremely important. So what can I as a pregnant do? You can optimize pregnancy and of course refrain from alcohol, tobacco and other drugs. Drugs still a big problem, a serious problem in our Arctic populations. So this is plain human health to talk about, not so specifically around pregnancy. But the main difference is that a pregnant woman also has the responsibility for another human being. That is the fetus. And of course, then if you destroy life conditions intrauterine, it's really a break of rights for the coming baby. So if you have, if you feel sick, you have symptoms, things are changing rapidly. Now you can do self-testing in Norway, and we have a continuous alarm for that. You can be immediately immediately detected if you can take the test, so you can get the answer even in a few minutes now as it's coming out. So things have been changing rapidly since it closed down here in March last year. So, and of course, the regular routines, mask, face mask, hand washing, if your birth should go as normal. So these are just plain things. I don't want to spend time on that because we might get some limited time at the end for this webinar. You can have family and friends coming and visit, but all is based on knowing things, diagnosis, detection of infections, and so on. So that is also part of the mental health side of this here. If we have really good routines, people should be allowed to have their friends, their family, their partner, and so on in the regular way. We just need to take care of the basic routines. And that is the same with a companion. If we should stop and go back to what I call the Stone Age, like we had when I started as an obstetrician, then it's a long way back to something that we don't want back. So what do we know about breastfeeding? It's highly recommended, even if you're infected. And coronavirus has not been detected in breast milk. And that is also really important to stress, because I even hear prophets say that you should avoid breastfeeding again. Same discussion we had around contaminants and health. Breastfeeding is highly recommended. And of course, those who have had an infection of breastfeeding, they often had a mild course of the disease. So this is also some general advice we need to stick to when we talk about this serious pandemic we are into. If you are healthy without symptoms, you should follow general advice on breastfeeding, like full breastfeeding in 6 months, we say, and also partly breastfeeding up to 1 year or even more. It's so important for the immune status of the baby. So, of course, these are general things. Good hand hygiene, hand washing. Try to avoid touching breast with your contaminated hands. And of course, don't use alcohol when you wash your breasts and so on. This should be obvious things, not actually connected to the virus, but keep them. Because what happens if you're in a serious situation, we often change our good old routines, and we need to keep them. So coughing, sneezing, it's obvious. Or cleaning, of course. These are just things that in my practice now, I have had a fantastic reduction of infections, because we have made a good routine together with my new associate partner, where we really disinfect all the surfaces we are in contact with. Door handles, mobile phones, everything. It's so easy to do it, and it's so effective when you start to do it in a good way. This is some place we should really almost stop a little, because we have now finally got studies on vaccines and pregnancy. They're coming more and more. So far, we really conclude that the vaccination is recommended. But if you have got your first vaccine dose before you get pregnant, then you should avoid the next dose during the first 12 weeks, the first trimester. And that is the plain physiology. This is the exposure window for a virus. So if you get your first vaccine before pregnancy and you get pregnant, wait with second dose until second trimester. Beside that, please go through your vaccination. And it's very important for this general aspect. Finally, I will do some more speculative thoughts about the COVID. And based on my work also on climate change, that is really affecting the spread of vectors and also viruses. So the question is, how will climate change affect the virulence? And can certain contaminants reduce the effect of vaccines? They have studies on that on the Faroe Island. And I think we can conclude also that this is not the last pandemic coming. What will happen next? We need to have precautions, and we also need to build in our old good routines to build new good routines. And also, will the increased temperature increase the mutation frequency? As you know that the COVID-19, there are a few hundred of these different coronaviruses. And what will happen with the mutation? So I'm just asking now, like we see in the Siberian tundra, on a picture from my old trips there, the tundra is opening into islands instead of being a tundra. What will happen with the vectors? What will happen with the insects? What will happen with the spread of the viruses? So travel in a COVID time, why should we? I have not been traveling abroad for since March last year. And the strange conclusion is that I've done my job in the same way, but in a much more electronic way, virtual way. On the other side, there are many side effects, those are not so good on that. So still the Arctic dilemma and the tropical dilemma, they're much based on food availability, food security, mental health should be mentioned here, because these are so important parts of the life in the Arctic and will be that in the years to come. And I think we can handle pandemics if we have a very good situation in that. So, tusen tack.
Thank you so much, Jon. That was also very, very interesting and inspiring. And it clearly shows the need for studies because in COVID and in different groups, because as a physician who normally don't deal so much with pregnant women, you readily believe pregnant women to be much more vulnerable to the COVID infection. So it was quite reassuring what you told us. Any questions? Well, you said one thing that I didn't quite understand. You talked about the virus or the vaccination window in the first trimester.
I see also I got an interesting question from Rochelle now about the statistics about the impact on the infants on the first year of life. We don't have any good big study on that yet, but I told about there are two sides of this. The first trimester, that's where the virus can go through the placenta, and that is why we avoid vaccination in the first trimester. Beside that, to have an immune response to the virus, there's no evidence that will harm the fetus at all. But this is more like a precautionary principle so far until we know more. But we know that the virus will penetrate and go into the fetus in the first trimester, and that's when all the congenital malformations can come. That's why we are so careful with that. And the same with Rochelle's question about the infant on the first year of life. That is why we promote breastfeeding, because if you start to a baby that has not the proper nutrition will not have the immune defense needed. So if you stay to our strategies so far, the prognosis for the first year of life is just as good as it is if you have a good health condition, good nutrition, breastfeeding, and it's like a regular situation. But it means that you need to keep the baby in good health, and I strongly promote breastfeeding.
There's one question more from Laura Eichelberger saying, anecdotally, I believe we're having quite a problem here with pregnant women not wanting to get vaccinated and ending up with severe COVID-19 in our own crowded hospitals. I was surprised to hear that women tolerate infection well. Could smoking, for instance, create greater risk of severe disease?
Yeah, I can answer very direct in that if you're a smoker, you might have easier to get an infection in the lungs. That's where also the COVID is mostly based. So there are this what they call a confounder here, or even a cause of more serious effect of COVID. That would be smoking. So I totally agree with this concern. And to get the pregnant women to get vaccinated, that has been a problem, because there are some people saying you should not do it to harm the baby or so. I mean, from my opinion, it's totally opposite when you think just try to avoid this first 12 weeks.
Any other questions? Well, in that case, I'll again say thanks a lot to Jon for your presentation. And our final speaker is Dr. Henrik Hansen, who is the Chief Medical Officer for the government of Greenland in Nuuk. And Dr. Hansen is probably the person in Greenland who knows most about COVID in the country, and I must say has worked most of all with the disease in the country. So Dr. Hansen will discuss the COVID-19 pandemic in Greenland. Please, Henrik.
Thank you very much. Well, it's a pleasure to have the opportunity to tell you a little bit about how the COVID-19 pandemic has developed here in Greenland during the last 1.5 years. I will try to share my screen. Just a moment. Okay, can you see the screen now?
No, we can't.
No.
What went wrong?
Dr. Hansen, I have your slides. Would you like me to try sharing my
I'll
slides?
I'll just try once more.
Okay.
Just a moment. Then I'm ready.
That worked.
Yeah, but it's the wrong screen. Just a moment. Give me one more chance.
Perfect.
Can you see it now?
Yes, we can, and we're seeing the right view. Thank you.
Okay, we'll start here. Well, before we start talking about COVID-19, I'll just give you a few words about Greenland. Can you actually see the right? I'm in doubt if you actually see the right.
Yeah, we're seeing the right
We
screen
do.
now, Dr. Hansen.
But you see slide 1?
Yes.
Okay, I'll try to go down. I really have some problem. Maybe you should take over because I can't shift from here for one reason or another.
Not a problem. If you want to stop sharing, I'll share your slides on my screen.
Yeah, that's better.
That'll work.
Now, wait a minute. Because I'll fix it right now.
Okay, you've stopped sharing now, Dr. Hansen. Did you want me to start with your slideshow?
Yes, okay, that's okay.
I will do that. Bear with me, I'm just bringing up the presentation. Okay, can everyone see the slide now?
Yes, we can.
Okay.
Okay, next slide, please.
One second, I'm having a similar problem, I think. There we go.
Okay, a few words about Greenland, just to give you an idea about what it is we're talking about. As you already know, Greenland is an island, and one of the great advantages in a situation like this, where you have a pandemic, is that it's quite difficult to get here. You can only get here from Denmark or from Iceland. The population here is rather limited, 56,000 people living here. In 17 towns and 55 settlements, the majority of the population living on the west coast. And nowadays, the population is also very much centralized. The capital of Nuuk is growing very, very rapidly, and more than 1/3 of the whole population now actually live here. Okay, next slide, please. Also, some basic information of importance when you're discussing a pandemic. 17% of the population is below 13 years of age. That certainly has some importance when you're discussing vaccination coverage, because that's higher in what you see in many other countries. But on the other hand, there are a few old people here compared, for example, to the Nordic countries. The mean age is only around 70 years, so it's considerably lower than in many comparable countries. And what also is of importance is that the educational level is below what you see in many other countries, and at least outside Nuuk, the quality of housing is not always that good. And even here in Nuuk, you often see people living under rather crowded conditions, especially because so many, they come in from the settlements and settle here in the town of Nuuk instead. Next, please. And a few words about the economy. It depends very much on exports of shrimp and fish. And a lot of the economy is also based on subsidizes from the Danish government. But fish is absolutely the most important source of income. The residents here in Greenland, they are generally rather well off. If you compare the gross national product per inhabitant with other countries in the world, you'll find that Greenland is in the same range as most European countries, although that it's lower than, for example, the Nordic countries. What is also of importance is that there are huge differences between different segments of the population here. If you look at what you call the Gini coefficient on disposable income, you'll see that the inequality in income in Greenland is considerably larger than the mean of Europe, and very much larger than in the Nordic countries. So to say it in other words, there are a lot of people who are well off, but there are certainly also a lot of people who have very limited income, if any at all. Okay, next, please. And let's turn to the COVID pandemic in Greenland and how it has developed. Like everywhere else, it started in March 2020, when we got the first case here in Nuuk. It took quite some time to find out that we were actually dealing with COVID-19, because at that stage we had to send samples to Copenhagen, some 4,000 kilometers away. And of course, that took time. But we had some cases, and we had a few secondary cases, but we were able to eradicate the virus from the country again. And for quite some time, there were no coronavirus in Greenland at all. That was when the original Wuhan coronavirus was still dominating. Later on, we had a few imported cases and a few secondary cases, but nothing really worrying. And then we came to May and June 2021. Then for the first time, we saw the Alpha variant from Great Britain coming into the country. And it made a small outbreak here in Nuuk, but we were actually also able to control that. Because a lot of things were done to eradicate it, and at that stage it was still possible. But then something happened. We got the Delta variant, and now we have a full-blown epidemic here in Nuuk, where we actually have, even compared to international standards, we have quite a lot of cases. And today, actually, here the 21st of September is the worst day in the pandemic so far, because yesterday we had 35 new cases. That's the highest number we have ever had during the pandemic. Next, please. And there are some interesting aspects of introduction of the Delta variant into Greenland, because it was really a game changer. And we have been able to follow what has been going on quite closely. So we know exactly that the first time we got in the Delta variant was the 29th of June, where a resident returned from abroad. And at that stage, everybody was checked on day 5 after arrival. And she actually turned out to be positive with the Delta variant. But as mentioned, she was vaccinated and there were no secondary cases. But then a few days later, in the beginning of July, an unvaccinated person a visitor came into the country, and he went down south on a quite long travel because he had several stopovers, and he brought the virus to the south of Greenland. And what was also interesting to see, we know for sure that he actually infected other persons on board the aircraft, the 4-hour travel from Copenhagen to Greenland. But we also know for sure that he actually infected others on board the small domestic aircraft. And we can say that for sure because at that stage there were no infections in Greenland at all. And there were certainly no infections with the Delta variant at that stage. And in a very short time, this infection actually spread to other towns in Greenland. And it's very interesting to see that the Delta variant was so much more contagious than what we had been used to. So those measures we have taken until now, they didn't work when we were dealing with the Delta variant. And since then, the virus has been here. It has probably been imported a few times since, but the majority of the infections probably came from this infection coming in the 6th of July. So it really gives some important information about how such an infection actually develops. Next, please. But what has the strategy actually been in Greenland so far? Well, as indirectly mentioned, the strategy so far has been to keep the virus out. And since the beginning of the pandemic, it has been mandatory to be tested before you travel to Greenland, even if you're vaccinated. And there were also quarantine regulations, and there still are for those who are unvaccinated. And if we see cases, as we do right now, well, they are isolated, and there are quarantine regulations for contacts. And until now, that has been sufficient to control the pandemic, and which also means that the country has been open. There has been very few general restrictions. There's been restrictions on number of travelers to the country. But you can say this society has been more or less open. And including in the strategy, of course, since January 2021, has been to vaccinate as many as possible in the country. Next, please. And a few words about the vaccination strategy. We got the first vaccines up here between Christmas and New Year last year. And it was the Pfizer-BioNTech vaccine, which was a bit difficult to handle here in Greenland due to the many restrictions on how to handle it in freezers with -80 degrees. And there are not many around of these kind of freezers here. In the beginning, there were very limited access to vaccines like everywhere else. We tried to get some vaccines for the remote Inuit-dominated areas, but we didn't succeed in that. Later on, the Moderna vaccine was approved in Europe, and we completely changed over to using the Moderna vaccine because it was so much easier to handle. And that has been functioning quite well since then. And here during the summer period in July, there were sufficient vaccines to all those who wanted to be vaccinated. And that really made a difference. In the end of July, we also started offering vaccination of pregnant women and lactating women. And of course, it was a little late because at that stage we had already been to all settlements in the country, but it's very difficult to get there. So those who didn't get vaccinated in the first round, we really have a catch-up problem. In August, we also introduced vaccination of children of the age of 12 to 15 years. And there we have the same challenges with those who are living in settlements far away, because we can't go back right away and offer them a vaccination. Next, please. And what is the status of the vaccination project now? Well, first of all, you have to take into account, as mentioned earlier, that there are more children here than in many other countries, which means that our coverage will never be as high as in certain other countries. At present, almost 70% of the population has got their first shot, but there's a remarkable difference to how many who have actually got the second injection. Less than 62% have got that. And it's not only because we have not been vaccinating the young for very long. It has to do with real serious problems getting everybody to turn up to the second vaccination. There's simply a larger gap than seen in many other countries between those who have got the first vaccination and those who have got the second vaccination. And when you look at those, only at the figures for those who are 12 years and older, you'll see that, well, it's going quite well. We're getting up, but it's still only 3 out of 4 who at present actually has completed their vaccination. And now we really have challenges with having those who have not been vaccinated actually having them vaccinated. If you look at the curve you see to the right in the bottom, you'll see that it's very difficult to get more new ones to have a vaccine. We are catching up on those who are to have their second vaccine, but it's real difficult to get hold of those who have not started at all. Like in every other countries, it's the same pattern you see, that it's those in the 20s who are most reluctant to be vaccinated. When you look at the very old, it's going pretty good. Next, please. And now we are in a situation where we are heading towards normalization. And that's somehow a new challenge because in one way or another, we have to live with the virus. But the problem is, when should we stop doing all the efforts we do right now and just let the rest of those who are not vaccinated getting them, allowing them to be infected? So what are we actually doing right now to avoid having too many infections? Well, you still have to be tested before you go here. And if you're not vaccinated, you still have to go into quarantine. If you're a non-resident, you can actually not enter the country at all if you're not vaccinated. And we continue to isolate all the positive cases, but we are challenged by that now, because with 35 cases in one day, we simply do not have a system which is able to handle such a high number of infected persons, and certainly not to ensure that all contacts are in quarantine. And there are still very few restrictions. It's very interesting to see that the politicians are at this stage not very willing to introduce new restrictions. There are a few restrictions here in Nuuk. For example, if you want to go into a bar, you have to prove that you're actually vaccinated. That's one of the few restrictions which are actually back. But the challenge is still, or the plan is still, to continue the vaccination program and try to get more vaccinated. And we plan in October that the elderly in the nursing homes, they will be offered a booster vaccine, and at the same time, vaccination against influenza. Next, please. So what has the impact been on health so far here in Greenland? Well, we have had about 500 cases, which means that less than 1% of the population actually have had an infection with COVID-19. And what will happen to these people? How many will have long-lasting effects? Well, it will probably be the same as anywhere else. We had very few hospitalizations. None of them has been serious, and nobody has died from COVID-19. So you also might try to ask yourself, have you actually been doing too much? Have we been putting too much effort into actually preventing infections with all the costs they've had? There's also been some negative secondary effects of all the interventions in the healthcare system, no doubt about that. A real lot of energy has been used on testing, quarantine, and emergency preparedness. And there has been less focus on other activities. For example, a disease like tuberculosis, as you know, is frequent here in Greenland, but there's been very little focus on that for 1.5 years, because we have used our energy on COVID-19. We have tried to keep up all planned services, for example, having eye doctors coming here and things like that. But it has certainly been challenged, and not everybody has got the services that they would normally have as a consequence of those decisions we have made, where we had put so much focus on the COVID-19 pandemic. Another interesting aspect is obviously that a lot of patients, they actually have stayed away from the healthcare system because they have been scared of getting an infection if they got there. And there are no doubt that there are some negative effects that we will see on a long term because of that. Next, please. And what about the economy in Greenland? What influence has it actually had? Well, there has been a lockdown in the beginning. We were scared when we got the infection for the first time. It cost us some money. And later on, there's of course been some impact on the economy, but not very much. The interesting thing is actually that the economy of Greenland has been rather good all the way through, and there has been no real losses. And of course, there has been a loss of income, but the most important cause of that is actually due to the fact that the prices on fish and shellfish has been falling on international markets because all the restaurants has closed all over the world. But of course, that has nothing to do with the interventions we have done here. We have had no influence on that at all. Next, please. And what about the social consequences of the pandemic? Well, it's more positive, you can say, no doubt about that. Unemployment rates, there hasn't been no unemployment due to the pandemic, or at least very, very few people, and they have been able to find other jobs. There's been a small group of people working with handicrafts, selling to tourists and things like that, which have not been able to continue these activities, and they have lost some incomes. But it is of no major importance. Those who are really making tourist business, they have been subsidized and have not really lost a lot of money. Most important is actually that the schools and the educational activities, they're functioning all the time. And there are no reasons to believe that that the pandemic as such has created more poverty than you already see in Greenland. So in conclusion, the pandemic has not caused major social disruption in the country. Okay, next, please. So to try to make a conclusion, well, has it been a good idea what we've been doing so far? That we have told the politicians that they should avoid having the infections? Well, it's maybe a little bit too early to say, but as for example, it was mentioned in The Guardian some time ago, eliminations likes to be the least bad choice for many restrictions. And at present, I also believe that it has been the best way to handle the pandemic in Greenland. But now we certainly have a real big challenge, maybe bigger than we have had so far, and that's how to get out of the pandemic. That is really a challenge, because it's difficult to find out when are you to stop and say, well, now we will just let the virus have its own life and let it spread freely in the society among those who are not vaccinated. And that's what we're really trying to find out these days. Thank you very much.
Well, thank you so much, Henrik, for also a very, very interesting presentation. It was so interesting to see not only the figures and the course of the pandemic in the country, but also the different consequences on society and other issues of health and so on that it has had. And I think your last remark of how we get out of the pandemic is very relevant, and it's a big question to many countries. Do we have any questions? Rochelle has a question.
Thank you so much for that excellent presentation, Dr. Hansen. One thing I do always remark on is how very similar the landscape and pictures of Greenland look to the pictures of rural Newfoundland and Labrador. Here on our island, migrant workers during the pandemic were an issue. We have a lot of people who live in Newfoundland and work in provinces elsewhere in Canada, particularly in Alberta, where the COVID numbers were higher. So it was quite a balancing act for governments here to manage that travel. And I'm wondering if there is a similar situation in Greenland with migration of workers and people traveling for work, and if there is, how it was handled there.
Yeah, there are very many people traveling back and forth between Greenland and Denmark, and the opposite way. And the way we have handled is that from the very beginning, everybody had a negative test even to board the aircraft. And we decided to do that because it was not possible to test people on arrival like you do in Iceland, for example, for simple logistic reasons. And until 1st of July, everybody should also quarantine for a minimum of 5 days in Greenland, and then they should be retested. And only if you were tested negative, you were out. We changed that 1st of July, where we accepted that those who were fully vaccinated, they no longer had to be in quarantine. And until we started dealing with the Delta virus, this system seemed to be very effective. But as mentioned, then things really started to be difficult. And now we know that those who travel back and forth, they will bring in more cases. But on the other hand, they will be vaccinated. And according to those figures that I have been aware of lately, it seems like those who are fully vaccinated, well, they might transport the virus with them, but it's very unlikely that they transmit it to others. Although we have actually seen 2 cases here in Greenland where fully vaccinated people for sure has transmitted the virus to others.
Thank you.
Sorry, Jon Øyvind?
Yes, thank you for, I would call it a very interesting sociological experiment you are doing. And of course, Greenland is an ideal situation that you have a quite closed community that you can test out your strategies. So you will have a lot of good experience for maybe for the next pandemic. My question is, do you know the difference between the Norwegian and Swedish strategies, where Norwegian was quite strict in every case in importing people to work or so on, while the Swedish authorities, they took a very much more open strategy to have a free flow of people in and out. It was a very bad situation in Sweden from the beginning, but the result now, it looks like both the morbidity and also how many people dying is quite coming into the same situation in the final stages we are now. What would you think about the 2 different ways to approach it?
Well, I mean, until now, you absolutely been very strict and trying to avoid all infections. And I don't think we really realized that it would be such a challenge to get a high vaccination rate, because that's really where the challenge is right now. Because if we could raise the vaccination rate to a maximum, there are no doubt that it would be the best solution to continue to be very strict until everybody is vaccinated. But now we have to realize that a considerable proportion of those 12 years and above, they will not be vaccinated. They are simply not willing to be vaccinated. And that's why we are in this situation where we have to find out, are we to give up now? Are we to wait another 3 months to hope that the vaccination coverage will increase? Or what are we to do? Because it is also, from all points of view, expensive to keep up all the regulations and all the other things that we do, including, for example, just having this system of testing all these people in this country is indeed very difficult and taking resources from the healthcare system, and thus it will also have a considerable negative effect on health, because all the efforts are put into testing all these people.
Thank you.
And Elske?
I'm from Manitoba, Canada, and we do have a very similar situation in some ways to the interesting situation you have in Greenland of such a large indigenous and population of children. And I'm a pediatrician, and I was very excited to notice that Pfizer is going to release their data soon, hopefully confirming, or I understand confirming the safety for vaccination of children age 5 to 12, which should do, I think, help a lot with transmission through schools and to our elderly populations. So 2 comments. One is I would urge all of us to not remove restrictions until children can safely be vaccinated with vaccine, so that it doesn't harm our children, even though it's less virulent in children. It still is harmful to some children with health compromises. And the other question I had for you is how, if it is the Pfizer vaccine that is going to be the safest for our northern and remote children, how are we going to get it to those remote communities in a blitz to vaccinate those children? Do we bring them all by plane to a central place where there is a -80 freezer? Do we take the vaccine in a mobile clinic with a mobile freezer to them? I'm just wondering about what experiences people have and how we're going to manage this. Thanks.
Well, it is possible to manage it also in a community like Greenland, but it is indeed difficult. I can give you an example how difficult it is. When we started up vaccinating in the northern part of the country, we got the Navy to, we used a vessel from the Navy, from the Danish Navy, who offered to do this twice, and it sailed to all the settlements in the north. And of course, it took weeks. It's very effective. It's not possible during winter time. And of course, it's very expensive, and you also need a lot of staff to be on the ship for such a long time. But that is the only way you can do it, I think. And it will not happen during winter time, as mentioned. So if we are to vaccinate, for example, children in the more remote places on Greenland, it will not take place before next summer.
We have a few questions in the chat. I think I'll say them or ask them, and then I'll sum up after that. And I do it in the pick the sequence as it fits. This is from José Lavoie saying, Dr. Hansen, can you explain the resistance to vaccination in Greenland?
I'm sorry, Dr. Hansen, I put you on mute by accident. If you could just press the unmute. Can anyone hear?
Kan du sætte ved en fejl blev muted, så hvis du kan unmute.
Now I think it's on. Okay.
Yes.
Okay. Well, unfortunately, I can't ask the answer because I don't know the answer. There are some religious movements in Greenland, but they do not have any major influence. So we don't really know, we don't really understand why there are this resistance. We're trying to find out, but it's indeed very, very difficult. So therefore, it's also difficult to do something about when you really don't understand what's behind this resistance. Thank you.
Then there's a comment from Leif Fraser Roberts saying, thank you for a very interesting presentation. Just a comment, as a pediatrician, I suspect we'll not see governmental efforts to reduce COVID transmission in the population cease until infants and children are also eligible for vaccination. And I can indeed say that this is a discussion going on in many countries. Then there's one question from Laura Auchelberger. It's could Wayne and Josie talk a little about how their findings are being used to address needs like food security? I know we jump a bit in the questions or in the presenters, but could you do that?
Wayne, do you want to start or do you want me to start? Okay, I'm not seeing Wayne on, so I'll start. So what has happened in Nunavut, we heard a lot about community hunts to fill community freezers and then hampers being distributed, especially to families where self-isolation was required. in Manitoba, in Winnipeg, we saw a community organization, the Manitoba Inuit Association, also starting a food hamper program and distributing food and PPE to community members here, and also with traditional food being shipped from the Arctic down so that traditional food could be distributed as well. But it's the same as a food bank, right? It's a stopgap to deal with a systemic issue, and the issue of poverty has to be addressed, and of marginalization, of racism in terms of possibilities of employment. And so that is a more of a long-term solution that the Manitoba Inuit Association will be working on with employability program, with advocacy, and so on and so forth. So there's the stopgap measure, and then there's the long-term. I'm not sure whether Wayne wants to add anything to this.
Wayne, do you want to add something? Yes, Henrik?
Well, here in Greenland, it is to some extent high-level welfare society, because the government takes care of a lot of things. And also here during the pandemic, for example, if there are families who need quarantine because they don't have sufficient space, it is to some extent actually offered by the government of Greenland. So we have not been in a situation where there are voluntary organizations and things like that actually starting taking care of people. It is a society which in many aspects is different from other parts of the Arctic, because the government takes such a large responsibility of what's going on. Thank you.
Thank you. I think the last question that goes to all of the presenters, so please answer as freely as you will. It's from Laura Eichelberger, and the question is, great presentations. One common theme I hear is delayed healthcare, particularly for those individuals who have to travel for medical services. Recognizing that our countries have very different health systems, do the presenters have any thoughts on how to address other health needs, considering that the health of the pandemic is not clear? And the question is in the chat if you want to see it.
I would like to respond. Can I do that? Because, I spent quite a lot of my life also in Africa. And that's where I really see some serious consequences. They have to spend very limited resources on the pandemic, and we lose resources for cancer, for environment, for many different serious issues coming up. So that's one of the serious side effects of the pandemic, that we lose control of the other health problems we have. So we really need to address this and focus this for the years to come, even when we try to take care of the pandemic. Thank you.
Henrik, do you have any comments?
Yes. Well, as mentioned earlier, we have had focus on it, but no doubt it's a real issue. But for example, in practice, we have actually accepted that some of these traveling teams who are to take care of specialized services, we have allowed them to travel despite the normal regulations of who could travel and who could not travel. And that's one of the ways that you can actually try to keep things as normal as possible. But I'm myself in doubt whether the price of what we have been doing for the last 1.5 years in some aspects actually is too high. Thank you.
Jose and Wayne, do you have any comments?
I can take a stab at this. The issue of the infrastructure in Arctic Canada is underdeveloped and has been under-resourced for decades. As a result of it, it is an infrastructure that is stretched in terms of the healthcare services. And it leads to utilization of services through travel. It's millions of dollars in travel every year. What we've seen through COVID is a shift in terms of more interest in virtual service delivery. And that is very significant. That's a great improvement. And there's been also innovations in terms of more deliveries being left in the Arctic as opposed to even the higher risk delivery or medium risk delivery being done in Iqaluit instead of Winnipeg, which is an improvement in itself. So sort of the shifting of that extroverted healthcare system that reach out to provincial sites of care, shifting that back to more localized care is an innovation. I think that's quite helpful. But of course, these economies of scales and recruitment and retention are going to continue to be complex and difficult things to overcome. I'm not sure how much needs to be invested in order to overcome that. But we do have, I think, in the Arctic, the highest rate of medevac across in the circumpolar Arctic still. And so that speaks to infrastructure issues.
Thank you so much for the answers. Any last questions, concluding remarks from anyone? Elske says, thank you all for presentations, very interesting and a lot of ideas for future exploration. So I would definitely agree. And just before I round up, I would say that I would remind you all that in June 24th to 26th, 2022, there's the next International Congress on Circumpolar Health in St. Petersburg in Russia. But finally, I would thank all of the presenters. I would thank the Newfoundland Center for Arctic Health Research and the School of Arctic and Subarctic Studies. And I would in particular thank all of you who attended this webinar for a very, very interesting 2 hours talk on COVID and the impact in the Arctic. I think all of the presentation. Sorry, I think all of the talks, they covered each of the aspects of this pandemic in the circumpolar world. So thank you very much, and I hope we'll be able to make more webinars like this, and in particular, we'll see each other in June next year. Thank you so much.
Thank you so much, Dr. Koch, and thanks everyone for joining us today. It was a wonderful opportunity to hear about so many diverse perspectives on this important topic. So on behalf of all of us here in Newfoundland and Labrador, thank you so much for sharing your knowledge with us today. Bye, everyone.